Mind you, I can probably talk an hour on every individual element of this talk. So it's going to feel as a rather superficial talk, but we'll try to give it a go. There's a lot of things to go through. And we'll start with history. So the next 3 hours, I'll be talking about the history from the 1600s. So I hope you can tuck in. So the first pretty much 100 years, give or take, we spent it figuring out what actually happens. We found that there's tubing, there's something that we call blood, and it sort of circulates inside. And the first blood transfusion was actually in a dog, from a dog to a dog, nothing kinky there. And then we started putzing around between sheep and dogs and cows and dogs and things like that. And this was actual science, mind you. First human transfusion happened a lot later, almost not quite 200 years, but give or take. A lady had a massive hemorrhage in the time around the delivery. And this was actually the first time it was successfully done. The patient was saved. And from this point forth is where history becomes actually very interesting, because there's an amazing boom on transfusions over the next, I don't know, give or take 73 to 18, whatever years. There's about 273 transfusions in the literature, and about 50% of people died. And we did not know why, but we were still doing it because it was fun. 1872, the Jehovah's Witness community is founded here in the States. I'll get to that later. 84, we found out that giving people milk is not as good as a substitute for blood. People tend to die. And we started using saline, which is sort of like a very basic water salt solution. Almost 400 years later, we figured out there's actually types of bloods. And very early on in the history of blood management, there was this moral imperative of some of us not taking blood transfusions. And this is where history splits between how I was trained, where I come from, which is politically incorrect here in Arizona, and other people, some of you got it right, good. And other people which had a different approach to this, and I'll get to that later. We discovered that there's such a thing as being positive or negative in the blood. We finally figured out how to separate the blood in its constituents, so you can separate the red blood cells, the platelets, the plasma, the sticky parts, and then we discovered how to store it. World War II brings us to finding out that transfusions and albumin actually saves people, caveat to that. 46 years later, from the discovery of the different groups of blood, we discovered that it's actually a good idea to match people to the blood they actually have. And later on, we found out that platelets decrease the mortality in people that have hemorrhagic shock when you're bleeding to death. In '64, mind you, it's been a while now. We've been in this history trip for a while. Cooley, which is one of the sort of pillars and cornerstones of cardiothoracic surgery, started developing some of the bloodless techniques for open heart surgery. And this actually was the second, perhaps, boom of bloodless medicine, because it's one of the big guys, and it's actually putting his stamp behind it. By '73, almost all the surgeries, at least in California that I can find in the literature, were being done in a bloodless fashion. Mind you, this is everybody, not just Jehovah's Witnesses. But you didn't know about that, did you? Good. Otherwise, I had nothing to say. So, 1983, we finally found that the preservatives will extend the life of blood, so you can store it for 42 days. That sounds appetizing. HIV, the warning comes as though it can be associated with blood transfusion. So in other words, you can get the infection out of a blood transfusion in the 80s, and yet the ban didn't come till way later. 2007, the first book ever to be written on how to actually manage blood was written, which is, I think, a very, very big milestone, as it were. And my favorite one of this, because I actually deal with this every day, Medicare decided not to pay in 2008 for any complication from blood. And that's what I'm going to give you a little taste of, which are the complications from blood transfusions. So normally when we think of blood, we think of it as a tissue that allows you to carry the oxygen and helps you with the clotting. It carries hormones and all sorts of fun things. And there's usually roughly a 4-to-1 ratio of how much reserve you have versus how much you actively need at any given time. And you've already heard it from everybody. We've been indoctrinated with this whole rule of 10/30. So we used to have this algorithm, and you drilled it to the residents by pain and suffering. And everybody would come out with this algorithm, but there was no science behind it. Mind you, I will show you some articles from earlier on. We already knew better, and yet we had not put 2 and 2 together. So whether this was right or wrong, we'll figure it out. I'll let you guys decide. So I want to talk a little bit about shock, and if you don't know anything about ICU, you're probably thinking about that. You're wrong. If you're thinking about Star Wars, you're probably thinking about that. And boy, there's people in the hospital. I wish I could just do that. I keep practicing. And that is just a cute monkey because I needed a third picture. Of course, I'm talking about a medical condition. And that condition is, it's whether it is an infection, your heart failing, your brain failing, it brings in essence, every single organ to its knees. And every single organ at once goes from performing well to performing sloppy, to starting to shut down, to dying. So there's stages to this, and eventually it can actually shut down the whole thing, and consequently you die. There you go. There's many reasons for it. We usually focus in my ICU on septic shock, which is an infection, and cardiogenic shock, meaning your heart just fails, which is not a good thing, but we're getting new toys, so we'll be good at that. The point of this is not to go through the whole thing, rather talk about how there's really stages to shock, regardless of what shock you're talking about. And in the first 2, your body can sort of handle it on its own. On the 3rd one, you may need a little bit of help. On the 4th one, you're starting to slip out. You may or may not respond to whatever I do. And this is a graph that I absolutely adore. I make my residents memorize it by heart, otherwise they fail. They tend to fail anyway, so it doesn't really matter. But the point of it is even if you don't understand it, you'll see that there's a point where eventually just kaput. And this is one of my favorite slides from all time, and this is correlating, and I'll get to this later. This is data from America. These are patients here who have had such a severe infection that their body's shutting down, and you're doing everything you can for them. And you'll see how the mortality raises just by virtue of age alone. So right away, you get the first insight that I want to share with you tonight. Sometimes, regardless of the insult intrinsically, there's an age difference that will put you in a special category that will make it so that you're more or less likely to respond to medical therapy. So, in other words, there's problems that can be intrinsically bad, and that is regardless of whatever other conditions are around it. So anemia is one of those things that if you have it, it'll make things worse, but correcting it doesn't necessarily make it better because you're still in the negative side of things. You still intrinsically have a negative problem. I want to spend some time here. If I had to summarize the last 4 months of ICU literature, there's a higher push on trying to not only see people for how sick they are, but how sick they are in relationship to their own health. In other words, how much health reserve do you have to put up with a particular punishment? And this scale, it's called the Karnofsky scale. There will be a test at the end of the session. Correlates roughly with it. So if you're at 100, it means you have no medical issues, you have no complaints, you're the sheer picture of gorgeousness and health, like me. If you're 0, it's awkward, you're dead, and 50, it's roughly where most people should be referred to hospice. It's people with chronic diseases, they're not responding to medications, they have 6 months to live or less. There you go. So this is what disease roughly, if you want to think of it that way, does to you. You're perfectly fine. Sorry, I drank too much Diet Coke. You're perfectly fine. You have a critical disease, and then medical therapy allows you to go up. As you age, inevitably you die. Now, this is where, good, you got it. The point that I'm trying to make here is, when you have less of a reserve, 40% disabled, requires special care, blah, 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 you'll see that a disease will bring you down closer to death, even though it's the same process. I can't really copy-paste them perfectly, but that's the idea. And sometimes medical therapy can substitute you to a certain extent, but inevitably you will die. That is a cardiac arrest. Somebody just dropped dead. That's sort of what it would look like. And that's another one that it's a happy, successful story. You know, you go down, you should be dead, you're not dead, we got you out. And that's roughly what I want you to see. So the short of it is let's say that I'm a Star Wars fan, you're a Sith Lord and you're fighting your old master, and somehow you got chopped into pieces and then set on fire. Anemia and transfusion is probably not the biggest problem in your mind right now. You know what I mean? So this is intrinsically bad, regardless of the blood count. So if I was on call and somebody calls me and they say his blood counts are 7, that's the least of my worries. I hope Schuneman can fix that. So in other words, the severity of the insult divided by how much health reserve you have is what determines whether or not you'll make a particular insult or injury, rather than the numbers in the particular blood work. Oh yeah, I don't own any of those pictures. I actually stole them. This is one of the studies that I was alluding to earlier, and if you remember my history lesson, this is early on, before we even started with the meticulous techniques that were developed by Cooley. 1958. If you have an anemia, and those are your numbers, 7 to 8, 0% extra mortality if you're going for surgery. 5 to 7, 9%. If you're at 530, less than 364. So we already knew that getting transfusions didn't make a big difference, and yet we did it. Because it makes sense. We rationalize it, whatever. So this means that if you're going for surgery and you're here, it's a bad thing. So your reaction would be like, well, fix it, right? No. Correcting the anemia does not decrease the mortality. And that's probably the biggest shocker we've discovered. That you can fix the numbers, you can make them look pretty, you'll feel better about it, patient feels better about it, but the reality is the insult is still there. There's something actively behind scenes still trying to kill you, and just correcting the numbers is almost like putting a little patch on it. Again, it's the severity and the insult and your reserve that determine if you'll make it, not the numbers. So when we talk about blood transfusions, everybody thinks, well, there's benefits to it, right? You increase the blood count. That's the first thing they'll tell you, and I've already proven that it's sort of pointless to some extent. Some people have rationalized it like saying it decreases the stress to other organs, which there's papers in critical care that say that's not necessarily the case.